The patients with acute severe asthma or status asthmaticus present in two forms, either with severe attack or with life-threatening attack. In severe attack, the patient will be unable to complete sentences. The respiratory rate will be more than 25 per minute. Pulse will be more than 110 beats per minute. Peak expiratory flow rate will be less than 50% of predicted value. In life-threatening attack, the patient will be confused or he will be in state of coma. The patient will have feeble pulse, bradycardia, respiratory exhaustion, silent chest. The peak expiratory flow rate will be less than 33% of predicted value. The ABGs will show type 1 respiratory failure. If partial pressure of oxygen is low and CO2 is high, it indicates type 2 respiratory failure. The first step in the management of acute severe asthma is the resuscitation. The first priority is to provide 100% oxygen to the patient. You have to nebulize the patient with oxygen. This involves administering a nebulizer treatment with medications to help open the airways. The medication typically used are salbutamol, which is a bronchodilator to relax the muscles around the airways, and ipratropium bromide, which is another bronchodilator. Then you have to give IV steroids. High-dose intravenous steroids like hydrocortisone are given to reduce inflammation in the airways. This usually takes 6 to 8 hours to work. A portable chest X-ray is obtained to rule out other potential causes of the respiratory distress, such as pneumonia or pneumothorax, which are the indications of collapsed lungs. If patient's condition does not improve with the initial steps, then it is considered a life-threatening attack. Magnesium sulfate is administered intravenously slowly over 15 to 20 minutes. It can be repeated, but the maximum dose is usually 4 grams. The patient continues to receive 100% oxygen with nebulization treatments and repeated doses of IV hydrocortisone. If the patient shows improvement, then they are managed as a severe asthma attack. They continue to receive nebulization treatments with salbutamol and ipratropium bromide every 4 hours. Once stable, the patient then is shifted to a ward for continued monitoring and treatment. After 48 to 72 hours of stabilization, the patient is discharged home with a step-up plan for their asthma management, following the Global Initiative for Asthma guidelines. If the patient continues to deteriorate despite the initial measures, then IV aminophylline is given. This medication helps to relax the smooth muscles in the airways. It is administered intravenously at a dose of 5 mg per kg over 20 minutes, followed by a continuous infusion at a rate of 500 microgram per kg per hour. Adrenaline, also known as epinephrine, is a potent bronchodilator and can be used in severe cases to quickly open the airways. However, it should be used with caution due to its potential side effects. If the patient condition still doesn't improve, the patient may require mechanical ventilation to support their breathing. Non-invasive ventilation tried initially using techniques like continuous positive airway pressure or bilevel positive airway pressure. If non-invasive ventilation fails, the patient may need to be intubated and placed on a ventilator.